My name is Gigi Chen. I'm a medical oncologist with Diablo Valley Oncology, and I don't have the nice, cool new technologies as Dr. Murkow was presenting. I will give a more general overview in terms of brain tumor, as well as some of the systemic treatments that we have for the brain tumor. So thank you very much for being here tonight. So some of the statistics, some of the epidemiology of the brain tumor impact in the United States. So in 2019, there is estimated 86,970 new cases of primary malignant as well as non-malignant brain tumors in the United States. And amongst that, there's the estimated 3,700 children will be diagnosed with brain tumor this year. Brain and central nervous system tumor are the most common cancers among children. This year, about 16,000 patients will lose their battle with a brain tumor. There are many types of brain tumor that exist. So we can see that the incidence rate of primary brain tumor that does vary, with age. So in the adult population, the most common primary brain tumor we see include meningioma. We also see glioblastoma, astrocytoma. It's less often do we see ependymoma, mixed glioma, oligodendroglioma. So how do people present with a brain tumor? In general, some of the general symptoms can include unusual headaches, seizures, some changes in terms of the memory, personality, behavior. There can be inability to process incoming information and visual changes as well as motor changes. And certainly depending on which part of the brain that the tumor is affecting, that it can affect sometimes, speech, motor, balance, memory. How do we diagnose brain tumor? The main way that we can diagnose brain tumor is through MRI. So we usually think about brain tumor as either primary brain tumor versus metastatic brain tumor. So primary brain tumor, they begin in the brain, they tend to stay in the brain, and they can be benign or malignant or anywhere in between. Metastatic brain tumor, they are cancer that occur somewhere else in the body, and they're always malignant. They travel to the brain. So a picture here on this side, we can see this is more of a classic picture of a primary brain tumor. And on the other side here, we see a picture of the metastatic brain tumor with multiple round lesions that's in the brain, pretty typical of a metastatic lung cancer or breast cancer. When we talk about brain tumor, we talk about different grades. So when we talk about a grade 1 brain tumor, these tumors grow slowly and they do not grow into nearby tissues, and they can usually be cured with surgery. On grade 2 brain tumors, they also tend to grow slowly, but they can grow into nearby brain tissues. They are more likely to come back after surgery than the grade 1 tumors. And grade 3 brain tumor, they look abnormal under the microscope. They can grow into the nearby brain tissue, and they are more likely to need additional treatments in addition to the surgery. Whereas grade 4, these are the fastest growing tumors. So glioblastoma is a type of the grade 4 brain tumor. They generally require most aggressive treatment. So in the adult population, as you can see when we're talking about glioma, and glioblastoma does occupy a big portion of that. The other ones, the lower grades, including the pilocytic astrocytoma and oligoastrocytic tumors and anaplastic astrocytomas. So many different types, diffuse astrocytoma. So another common type is the meningioma. So the meningiomas, they arise from the meninges, which is the covering of the brain. So here we have a picture that shows the tumor here, that's meningioma. And they commonly are slow-growing type of tumor, and they may not recur if it's completely removed. A person can have neurologic impairments if it's pushing on a functional area. So, for example, if it's pushing on the optic nerves, people can have visual problems. This is a malignant glioma, which arises from the glial tissues, which surrounds the nerve cells in the brain. So this would include, the astrocytoma, the oligodendroglioma, mixed gliomas, as well as the glioblastoma. Anaplastic astrocytoma, on the picture here, it is a higher grade. It's a grade 3 astrocytoma and glioblastoma. Okay. What are the risk factors for brain tumor? So prior radiation is a risk factor for brain tumor. Other things include family history, so certain genetic conditions, neurofibromatosis, von Hippel-Lindau, Lee-Fraumeni. So some of the family history can be important risk factors. So when we have a diagnosis of the brain tumor, the surgeon would obtain they either resect the brain tumor, or in the setting, if the brain tumor cannot be completely resected, we would obtain a biopsy of the brain tumor. We are now learning more and more about the biology of the brain tumor, and we're looking at certain mutations in the brain tumor that help us in terms of classifying the brain tumor, as well as helping us to learn about the prognosis and also which treatments work better. Okay, so prognostic factors, everyone wants to know, if they are diagnosed with a brain tumor, how they're going to do. There are many things that factor into it. A person's age, how functional the person is, and whether the tumor is affecting normal brain function and everyday activity, the type, the grade, some of the prognostic genes. So for a glioma, the IDH status, for glioblastoma, the MGMT. So those are some of the genes that can be, prognostic or predictive in terms of how people respond. How much of the tumor can be removed by surgery, and also whether the tumor has spread to anywhere else, such as the cerebral spinal fluid, or other parts of the brain and spinal cord. So treatment would include surgery to remove the tumor bulk, radiation to disable cell reproduction and shrink the tumor, and chemotherapy to either kill the tumor cells or interfere with the growth of that. So I think that a big part that's under a lot of investigation, clinical trials, and what we look for in the future, hopefully for many, new treatments in the area of systemic therapy. Those include chemotherapy, targeted therapy, as well as immunotherapy. So what are the differences? Some of the most common treatments in glioblastoma, so Timidar, that's an oral medicine that is a chemotherapy drug. It's a chemical that goes to kill the cancer. Bevacizumab, the other common name is Avastin. That's what we call our targeted treatment. And what it is that it's a monoclonal antibody, and that targets against something called a vascular endothelial growth factor receptor. So in essence, it blocks the blood vessel formation, blocks the blood supply that feeds the cancer. So we call that to be a targeted therapy. There's also this new field of immunotherapy in cancer. And that's completely different from the previous chemotherapy or targeted therapy. And the way immunotherapy works is that we think our immune system should be able to fight the cancer, to kill the cancer. But the cancer gets to be really smart, and what they do is they put a brake onto our immune system. And the immunotherapy, there are different types, and what they do is there are intravenous medicines that we give, and in the body they kind of take that brake off of they unleash the brake, so that our immune cells, the T cells, can go around to target the cancer. So that's the theory behind the immunotherapy, and we do see that. For a subset of our patients, the immunotherapy works very well across different types of cancers. It doesn't work for everybody, so our goal is to find out, one is how do we find the patients that this works the best for, or are there ways we can make it work for more people? So this is something that patients are very familiar if they have a high-grade, glioma. So after the surgical resection, people get a combination of the temozolomide and the radiation together, and that's for the 6 weeks. And then after that, then the radiation is completed. Then people go on to take the oral chemotherapy 5 days every month, for a course of 6 months. So that's a fairly standard treatment that we use now for glioblastoma treatment. Okay. What are some of the new targets that people are looking at? And those, we look for something called driver mutations, or change in the molecular sequence in the cancer, and that really turns on the cancer growth. So those are the things that drives the cancer growth. So we're starting to learn something, some driver mutations, for example, in the glioma, NTRK, BRAF, FGFR, IDH. So those are things that can be, sequenced. And, all of this is still in the research phase. But I think there is, the goal is if we can find things that turn on the cancer growth, maybe we can find a drug that targets it to turn off the cancer growth. So this is a picture that shows the immunotherapy. So this is a young patient, a pediatric patient, and this is a picture of a malignant glioma. So you can see that on the side where the red arrow is where the tumor is. And then the nivolumab is one of the immunotherapy medications, and that's the patient received it for 12 weeks, and that actually, in this situation, this patient had a remarkable response. And we do see, again, for a very small selected population, that this can work, wonderfully. And we are seeing that in some of our patients as well. Again, the goal is to find out, who these medicines are great for, and also are there ways that we can use medicine in combination with something else to make it more applicable, for more patients. So we all know side effects of the chemotherapy that can include hair loss, mouth sores, loss of appetite, nausea. The side effects for the immunotherapy are a little bit different, So those can include the way we think about it is that if we turn on the immune system too much, and that may attack some of our own organs. So people may get a skin rash, people may have, thyroid problems that we put them on thyroid medications. So sometimes people may have diarrhea, so it's a very different set of the side effect that we still need to keep a very close eye on. Now, we'll talk briefly about brain metastasis. So if we look at the different cancer types that's in the body, some of the common ones that can go into the brain include lung cancer, breast cancer, and melanoma, probably the more common ones. Other things, kidney cancer. When we are talking about metastatic disease to the brain, Dr. Markow was showing this fascinating new technology, about the laser treatment for brain metastasis. And we'll also hear from Dr. Rembert about radiation. Some of the things that as a medical oncologist we can offer include some of the newer targeted medicines. And the targeted medicine, the way that works is, again, we find what drives the cancer growth. And if we can give a medicine that specific targets that, then it should work better and there should be less side effects. So we do have some of those drugs that are now working quite well for brain metastasis. So in the field of lung cancer, in the field of breast cancer and melanoma, we are having, we now have a lot of data in terms of the oral medicines that actually work well in the brain. So for lung cancer, it's actually fairly common that people can have brain metastasis. So for patients who have something called EGFR mutation, 31% of the patients with that type of lung cancer at diagnosis will have brain metastasis. And when we're looking at an older generation of the medicines, an oral medicine targeted drug versus a neuromedicine, what this shows is that this is the reduction of the brain metastasis by the medication. So we can see that, and the red line is complete response. So we can see that with some of these oral medicines, a significant amount of patients are actually having complete brain response with these oral therapies that cross the blood-brain barrier. So that was very, very exciting news. So now we kind of rethink when a patient is diagnosed with a brain metastasis, do we give whole brain radiation, or can we use this medicine, to trying to shrink the cancer to spare people, of some of the radiations. So this is actually very, very exciting. This is a different type of medicine called alectinib. Again, in lung cancer, we can see that it is penetrating the central nervous system as well. Let's see. So certainly, I think for anyone who has diagnosis of primary brain tumor as well as a metastatic brain tumor, they need a team of the providers to help them walk this journey. So that includes a neurosurgeon, medical oncologist, radiation oncologist, neurologist, physical therapist, occupational therapist, so important, speech therapist, ophthalmologist, psychiatrist, endocrinologist. So really, really, a village of people to help them through this journey, and also family, friends, all the support system that is so important. The support groups are just fantastic. So what is my dream? Some years from now, what we can do is when we have patients with brain tumor, or other type of tumor, if that patient can have the same diagnosis, but the molecular profile can be different. The drivers can be different. So instead of giving everybody the same treatment, with the diagnosis of a brain tumor, if we can sort out what drives, each cancer's growth, maybe we can separate everybody and give them a more personalized treatment. Give them targeted therapy, give them immunotherapy based on what we learn about the biology of these cancer. So maybe one of these days, we can just take our sequence and get our pill that day. So that would be what I would like to dream about.